Hello, I'm Andrew Suskind, and I'm a psychotherapist and author based in West Los Angeles since 1992, specializing in trauma and addictions. Welcome to our podcast, which I call It's Not About the Sex, also the title of my recent book. Here we focus on all topics related to compulsive sexual behavior, often referred to as sex addiction. In particular, we explore ways to build long-term, sustainable recovery while establishing more meaningful connection and greater intimacy. Our intention is to offer fresh viewpoints, brand new perspectives, and practical user-friendly tools toward living a more deeply connected life. Let's get started. Tom graduated from Springfield College with a Bachelor of Science in Human Services Addiction Studies and also completed his master's degree in mental health. He is specially trained in substance and process addictions and has had extensive training with Dr. Patrick Carnes, the founder of the International Institute for Trauma and Addiction Professionals. Tom is a licensed mental health counselor, certified trauma therapist, certified sex addiction therapist, and certified multiple addictions therapist. He has been working in residential treatment since 2003, conducting process, experiential, and psychoeducational therapy groups. Tom has an expansive education in process addictions, including gambling, gaming, and internet addictions. And he is an international speaker and trainer who has educated other clinicians in trauma work throughout the United States and on 3 continents. Welcome, Tom Pecca. So great to have you here with us today.
Thank you, Andrew. It's an honor to be on the show.
Thank you. And I just want to let the folks listening know that we are here, of course, in our usual recording studio in Los Angeles. And Tom is joining us from Florida. And I'm wondering if you can just let us know where exactly Ocala, Florida is.
Ocala, Florida is about an hour and a half northeast of Orlando, Florida. So we're smack dab in the middle of the state. We're towards the northern end. Some people consider us South Georgia or North Florida.
And also, I need to mention that Tom is a senior clinical advisor with the Guest House-Ocala. And I'm just so glad that you could join us today. I've actually known about the Guest House and its origins for many, many years. And it's really one of the premier trauma treatment programs internationally. So it's exciting to have you with us.
Well, thank you. We like to think it's the premier, but I'll take one of them.
Okay, the premier. No, but what's so great about it is there was a time, as you and I know, that there were no trauma-specific treatment programs out there.
Yeah.
And you're one of the few that really has been a pioneer and has paved the way for trauma treatment to expand to other parts of the country and other parts of the world. And on a personal note, I'm curious, what brought you into this specific field?
I mean, that can be an interesting story. My mother is actually Judy Crane, who's a very well-known trauma therapist. And for years, she was a clinician, I wasn't. We were 2 recovering people down in South Florida. And we were watching people in our 12-step groups and watching them struggle, and people were not being able to stay well as long. They would get to 4 or 5 years and they would get to the point where there would be relapse. We had a couple of suicides in our group.
Mm.
And Judy was working at a facility called Wayside House, which is a women's facility. And she was watching how many of the individuals that were coming in for addiction work were really trauma clients as well. And it drove her to start a program, another facility that we were involved in, and we sold about 4 or 5 years ago. So about 17 years ago. And I wasn't a clinician, and I was trying really hard not to follow in my mother's footsteps. I didn't want to be that person, and I'm sure you understand.
Yes.
But I came up to work there, and I came up in the business end of things, and I was running the business, but I was a 12-step person, and I started to do some 12-step groups for the clients, and they started to request doing work with me, and I realized that my mother and I shared some skills, and I was just drawn to it, and it really, watching people getting pieces to help them move forward that had crippled them for most of their lives. And I went back and I got certifications, and then I went back to school and I went back and got my master's. And for the past 17 years or so, I've been doing this work, and I'm very glad that I fell into it, and it truly is my niche, I believe, and I love doing it.
That's great. And one thing, just to add a little bit of background, is that your mother, Judy Crane, I've seen speak a few times and is truly one of the role models out there of folks who identified trauma as being inseparable from addictions. And because I started in the early 90s, we didn't quite get that back then. And I'm so grateful for people like your mother who have really put together the pieces of the puzzle and have helped us really create more cohesive treatment approaches. And one of the things that we say nowadays that you mentioned is the idea of trauma work. And I'm wondering if we can just pause for a second and talk about what that really means, trauma work.
Oh, absolutely. I guess to put it into context, when I started in this business, the theme was that you don't do trauma work with anyone in recovery, early recovery, because they'll relapse. But the truth was they weren't staying sober because they didn't do the trauma work. And what our philosophy is and what we believe, and this isn't any addiction, process addiction, or substance abuse, or for that matter, depression, anxiety, all the different things, is we truly believe that oftentimes those are really the symptoms of the underlying issues. So we're reaching out for coping mechanisms to deal with these things that happen to us in early childhood or later, that don't make sense to us, that overwhelm our nervous system, that put us in a place where we're not functioning. We need something to avoid that, to dissociate from it. And all addiction is dissociative. So
Mm-hmm.
we run to find something, and maybe that thing is alcohol, or maybe that thing is sex, or maybe that thing is food, or lack thereof, to avoid feeling those feelings, and those become the addiction. So if you have someone come in and you only deal with the symptoms that are presenting and you don't deal with the underlying issues, they tend not to get well. So trauma work is working on the underlying issues. It's really going back and reprocessing the things that happened to us that created the need for the substance or the acting out behavior in the first place. It's putting it in a different context so that we don't need that coping mechanism in the same way. That doesn't make us less of an addict or less of an alcoholic. We certainly, once you're there, you're there. But it
Mm-hmm.
often makes it easier to not go back to that coping mechanism in the same way. Does that answer your
Mm-hmm.
question? Or
It does. It does. And what I would just add to what you're sharing, which is so significant, is that once again, this was not understood
no?
30 years ago. And what you are sharing, which I think we forget that it's so new in our clinical understanding, is that trauma healing is so much about regulating the nervous system,
Absolutely.
and trauma healing is so much about doing whatever it takes to help somebody's nervous system regulate or find its way back to regulation more efficiently, so that there's this opportunity to stop the compulsive addictive behaviors. Is that accurate?
That's a completely accurate. And actually, I think it's really important to look at it that way, because I think people look at addiction and look at trauma as a mental health disorder. I mean, first, and it certainly is, but it is post-traumatic stress disorder. It's a disorder of stress. It's a disorder of the nervous system. It's a medical disorder. And if we don't treat it in that way, we're missing a step. And you're right. For years and years, we didn't do this type of work for whatever reason. It was intimidating to some clinicians. It was scary that we might stir stuff up that we couldn't handle, or we weren't in the right setting to do it. I was in a class. I had a professor who's very, very famous clinician who I'm not going to name, who relapse prevention was sort of his thing. And we were talking, and the discussion came up, and I said, well, what about working on their trauma? And he looked at me and he said,
Mm.
if you work on on their trauma, you'll kill them.
Mm.
And that was kind of he was very old school, and
Sure.
that was the way that they thought. And my thought process, if you don't work on their trauma, if you don't help them regulate the nervous system,
Hmm.
you're more likely to have that consequence.
Yeah, I mean, it's amazing how far we've come in a fairly short time. And I think for our listeners to know that this is actually cutting edge work, that this is really about doing whatever it takes to help the individual heal their trauma in a way that also will be healing and preventive to whatever the addictive compulsive cycle might be. And so along those lines, I'm curious if you have a way to describe kind of the core or the foundation of your approach, or maybe your program's approach to doing trauma work.
Ooh, it's a complex thing to do, but I think I can do it.
Do your best.
I think first of all, you have to think about the way that the brain works. And when you're looking at the brain, if we simplify it to the triune brain, the three parts of the brain, very simplified. We have the forebrain where logic lies. We have the midbrain where emotion lies, and then way at the back we have the lizard brain, the part of our brain that runs on instinct and survival.
Mm-hmm.
That's the part of our brain that's traumatized. That's the part of our brain that reacts on fight, flight, freeze. So talk therapy in and of itself, while it is useful, is not enough to bridge that forebrain and that lizard brain.
Mm-hmm.
It can get you to the emotional brain, and we've certainly seen that. So our philosophy, foremost, is experiential. That we're trying to do things like psychodrama. We're doing things using artwork. We're doing things using story. We're doing things. Even when I do a presentation, my presentations have a ton of music in them. They have a ton of video and pictures in them because they hit a different part of the brain.
Mm.
They hit that part of the brain that runs on that instinct. So I guess that's the foremost part of it. The second part of it is we work on what we believe. I mean, the one thing that we can prove anywhere, and the studies have shown, is the most important connection for someone to heal is their therapeutic alliance. Do they
Mm-hmm.
believe in their therapist? Do they believe their therapist knows what they're doing? Do they have that connection? So dyadic attachment is a huge part of what we do, and by dyadic attachment, it's that attachment between those two people. It's making a team. Same way the
Mm-hmm.
12-step works in a lot of ways. It's that place where we get with our sponsor, where we know we can trust them and we can say whatever we need to do, and we'll be loved no matter what we say.
Mm.
Our philosophy is really love them back to health.
Mm-hmm.
But within that, I mean, there has to be some confrontation also. Um, so I've always said, to be a good trauma therapist, you have to be a good improvisationalist, and you have to have one heck of a good toolkit.
Mm.
There is no one way to heal trauma. You have to be
Mm-hmm.
able to meet the client where they're at, pull the thing out that they need in that moment. So we might use psychodrama, we might use EMDR, we might use ART therapy, we might use actual artwork therapy, we do a thing called a trauma egg that's very well known. I believe Marilyn Smith created it, that many places do, where we present all of the traumas in the life, and then we find the themes, and we help look at how we're recreating those themes and some of the reactions that we're having. And it's about understanding your trauma reactivity,
Mm-hmm.
because we all live in trauma reactivity to some extent,
Mm-hmm.
and how to recognize it quicker,
Mm-hmm.
mitigate it sooner, move through it. There is no get over it. There is
Mm-hmm.
no it's over. It's how do I learn to move through these reactions quicker
Mm-hmm.
so that they don't happen as often or last as long. It's really about trauma is about intensity and frequency, and trauma healing is about lessening intensity and lessening
Mm.
frequency.
That that's so important, what you're saying about the fact that there is not one size fits all for this, that there are many different modalities and many ways to really heal the lizard brain. What I hear you saying in that, if I'm not mistaken, is that there's also a combination of the relational attunement and the neurobiological attunement. And what I was always taught is that the therapeutic alliance is the core, that's really what helps somebody's nervous system actually relax and feel safe and feel trusting, etc. So that's the beginning. And then there's one nervous system talking to another
Absolutely.
nervous system. Yeah, yeah. And I love what you're saying about the expressive therapies, because I think sometimes those of us in private practice don't always keep track of everything in terms of art and music and psychodrama and things that are going on all the time in treatment programs like yours. And then adding on things like EMDR and other somatic therapies,
Hmm.
et cetera, that there's really an opportunity to pick and choose and like you said, depending on the client, determining what really is going to fit for them, because everybody's nervous system is so different.
Absolutely. And I'm certified in many places, and I've taken a lot of different courses. I'm not certified in somatic experiences, but I think I'm somatic experience 3. I've taken EMDR, ART, all these different things, because one of the mistakes that I think we make as clinicians is we get very good at what we're good at,
Mm,
and we kind of expect a client to fold into what we do. And most times that can work, but we have to be open to the fact that this client may need something different.
mm-hmm,
Um, as a clinician, we should always be learning, always be adapting,
mm-hmm,
always trying to something new. And when you're talking about some of the polyvagal things
mm-hmm.
and matching the client's nervous system, I say that all the time. You're lending a client your nervous system. You're the same way a parent does, and
Yes.
and a lot of the clients that I work with, their parents lent them a wounded nervous system, and that's how generational trauma
Right.
passes on. So yeah, I agree with everything you're saying.
So I wonder if we can backtrack a little bit, because what I heard you say before, and I'm paraphrasing, but we all know that CBT and cognitive behavioral therapy has a lot of valuable
Hmm.
applications, and yet it's mostly attending to the thinking brain, and so um, how does trauma in general, how does it seem to influence relapse on folks who are dealing with compulsive addictive uh, behaviors of any kind?
I think if we also change the way we look at trauma, I think sometimes we look at trauma as only the big, huge things. But what trauma does is it to
Mm,
be a little more fragile, a little more likely to handle stress in a different way. And that doesn't always look like fragility. Sometimes it looks like dissociation. Sometimes it looks like codependence. Sometimes it looks like nothing is affecting me, but it really is. The reasons we relapse more often than not are stressors and our ability to deal with that stress. PTSD directly affects that. Trauma directly affects that. So if you don't understand how to regulate your nervous system, you're going to find something else to regulate it. So if I am doing well, say I went to treatment, I did a great job, I put everything I had into it. Um, I'm working my butt off. My family did some work, and then I go home, and those same stressors are there, and I don't have a way to handle those stressors. I'm going to go back to the thing that works. And the thing that works might be porn. The thing that works might be alcohol or heroin, or it might be overeating, or whatever it might
mm-hmm,
be. We utilize those coping skills because on some level they work, and they usually work quickly. So
mm-hmm.
if we haven't worked on and I much prefer talking about trauma reactivity than traumas. If we haven't worked on our trauma reactivity, we're going to have to find something that's where it leads to relapse there.
Mm,
And also, if you go back and your family hasn't done their piece of work, and you're going back into a family system or a work system that replicates some of those traumatic things, it can take you right back to the place before you did the work. And if you're trying to function within it,
mm-hmm.
you're going to fall back on the things that you know. um, and CBT does have a place. it,
Yeah,
it
yeah,
absolutely has a place. I don't want to sound like I'm
right.
saying no, because we need that as well.
What I think I didn't quite come full circle, but what I was trying to say about CBT is that it really is part of the story and part of the healing. But what you're really talking about is a deeper, more sustainable kind of recovery. And and I agree, by the way, around families, I think all of us tend to uh, go back to various kinds of triggers and end up feeling like little kids sometimes when we're around those old patterns. So I couldn't agree more with that.
I was telling a story today. I was doing a lecture today, and there's this story I have about when I was 3 years old, and my mother was still an active addict at that time, and she took me to a place where she was going to score drugs, and she left me alone for a minute, and there was this dog there, and this dog jumped on me and tried to bite me and um, attacked me. Now, her story would tell you that she went to this place, she left me alone. There was a puppy there. The puppy decided to play with me, and I got scared. But for years afterwards, if a dog came at me, I would be 3 years old again. So it's not just that we feel like kids. The way
Right.
that trauma works is you're reliving that moment. So part of your
Yeah.
brain is 3 years old in that moment. Part of your brain, you're actually,
Right.
so in that moment, it's very easy to do the thing that worked in that moment, or react in the way we react. And we see how many of us go back to Thanksgiving knowing I'm going to get in a fight with this person or this person. This is going to happen this Thanksgiving at some point. What I believe is those behaviors are simply our brain falling back into the patterns of traumatic reactivity that we knew.
Right. Right. By the way, I love the term trauma reactivity because I haven't used it before, actually, and I'm going to borrow it from you because it not only makes a lot of sense, but it's descriptive in a way that I think can help a lot of folks normalize what that dysregulation is really all about. And that idea of going back to feeling like the 3-year-old is exactly what trauma does. It's kind of like a temporary hijack of the brain. You know, a lot of our listeners
Yeah.
are in recovery from various kinds of trauma and various kinds of compulsive sexual behavior. And I'm wondering if we could talk for a moment about what you would consider to be healthier sexuality.
That's a really good question. And I don't think there's one answer to it, because I think healthy sexuality is an individualized thing. Um, there is no, if you're not harming another person or animal for that matter with the behavior, there is no good or bad in sexuality. But I like to look at healthy and unhealthy choices. There are things that are healthy for me that would not be for another person, and there are things that are unhealthy for another person that would not be for me. So for me, as a recovering sex addict, I have to look at really, number one, live in consultation, and be able to have people that I can trust to run things by, that they're going to tell me honestly and truthfully what they believe about what they're seeing and what I'm saying and the choices I'm making. Um, but I have to honestly look at myself, and is this something that I'm drawn to because of the intensity of it, or is this something that I can do in a healthy way and participate in without it harming me? Um, and that's a difficult thing to do as an early
Mm-hmm.
recovery person. That's why we do the three circles of the green, yellow, and red, and really look at behaviors I have to really monitor. So healthy sexuality is a process, and in the beginning, you know, I might have to be restrict a little more of things that maybe I want to participate in. And as I go forward, I start to see, okay, can this be something that can be part of? And I may try something and realize, no, this isn't healthy for me. I need to let go of it. One thing I did once, I had a client I was working with who's a trauma survivor who had horrible physical abuse from his mother. Well, he had been married for 5 years to a woman, and they were in an S&M relationship. She was the dom and he was the sub. And he's talking to me about it. He says, "This is my life. You can't ask me just not to do this anymore. This is who we are." So, and I looked at them, and what we did is we went behavior by behavior. And with the two of them, we had a couple session where we negotiated behavior. And I would say, you want to do this? Well, let's look at your history and where this goes. And how does this replicate this? And well, this thing doesn't replicate. And we had to actually talk about all of them. And I think that part of healthy sexuality that's difficult a lot of times is we want that intensity and we want to feel it now and feel good. And to be a healthy sexual person, I have to take the time back to sit, reflect, honestly, negotiate with myself of what is okay and what is not. Kind of similar to if you're working a food program, there are certain foods that are just fine for somebody else, but if I eat them, I know that I'm going to have a binge or I'm going to do this. So I might not be able to have a Snickers bar, or I might not be able to, much as I want it, as much, and I have to deal with the fact that somebody else can. So, but I got to look at maybe there's another food that is okay for me, that doesn't trigger these things, that I stay in health. And I've got to look at my behaviors. And if my behaviors are changing, I've got to decide that maybe these things aren't good for me. That's kind of my feel on healthy sexuality.
Sure. And just to elaborate on being in consultation, I want to share a little bit about how I see that. I'm always in consultation, and my primary people are my therapist, my sponsor, and God. And of course, I have others in my life, people in program and others who I trust and I can be fully myself with. But I wanted to just highlight that idea of being in consultation because for me, it's about being current, being honest, being transparent, and allowing myself to be seen fully for things that I'm just not sure about, right? Like getting a reality check in a way. And for those of us in program, I think that it's a lifetime deal. That, at least that's what I found. And actually, I feel less alone in the world based on that. And I actually feel more regulated in the world and less anxious in the world as a result. And so I just wanted to highlight that idea of being in consultation because it doesn't matter whether you're in a formal 12-step program or not. It just matters that you have emotionally reliable people that you can check in with.
And that you're being completely honest with them. I was working with a client the other night, and she has some sexual compulsivity, and she was checking in with me, and she goes, "I haven't met up with anybody. It's good. I haven't acted out." And they said, "Well, are you texting anyone?" And she decided that she didn't want to tell me that until I asked the question. To truly be healthy, if I have to keep it secret, it's probably not healthy.
Mm-hmm.
If I can't tell the people I trust, probably shouldn't be doing it.
Right.
So and again, that she was texting a few people, and that and so you're on a slippery slope if you're doing that. If you have to hide it, don't do it.
Right. Right. So my last question has to do with attachment. And again, this is so interesting to talk about attachment around trauma and addiction and compulsive behavior recovery, because again, there was an old school version of attachment that was back in the days of Bowlby, who really talked about secure attachment and insecure attachment for the first time. And then there seems to be this new wave this last 10, 15, 20 years where everybody's talking about attachment again. And which I love because I think it's so much a part of what happens between therapist and client. But I'm wondering if you can just talk about, from your perspective, what part do you think attachment plays in trauma recovery, in addiction recovery, and sometimes in people stumbling and fumbling and going into relapse?
I think attachment is so important, and I think it's part and parcel with trauma, part and parcel with addiction, especially sex addiction. Sex addiction, it shows up even more so than most. But if you think about it, the makings of a sex addict is a rigid, disengaged family system. At least that's the initial research. Well, that creates, so many of us are avoidant attachment in sex addiction. We're looking for something that is intense and quick, and then I don't have to attach too much to it because that doesn't feel safe because of whatever happened to me in childhood. If somebody got too close, they would abandon me or they would hurt me, or all these different scenarios. Or on the other side of love addiction, where I have this abandonment and neglect, where if I don't have someone to complete me, I'm not okay. I'm going to find ways to feed that belief system, that internal attachment, because attachment at its core is a belief system about the way the relationship works. It's an expectation of what will happen if I get too close, if I don't get too close. So that, to me, it's much easier for many of us as sex addicts to go to pornography because there is no actual attachment to it. it is easier to have serial relationships because I can have an intensity that feels like it's something that, because addiction is intensity and recovery is
Mm-hmm.
non-intensity. It's intimacy. So I can
Mm-hmm.
have that intensity without the intimacy. So it completely
Sure.
sets us up for relapse. And trauma is the same thing. If you are abused in some way as a child, it's going to affect your attachment no matter what you do. You're either going to learn to trust or not
Mm-hmm.
trust, or trust to a certain extent. The easiest way for me to explain attachment to people is usually that, that healthy attachment
Mm-hmm.
is I'm okay and you're okay. And avoidant attachment is more of I'm not
Mm-hmm.
okay and you're not okay. And that insecure attachment is I'm not okay and you'll make me okay.
That's right. Yeah.
You know? And then disorganized is I'm okay and the rest of you are messed up.
The world is messed up. Right.
So it's more
True.
about those systems of meaning, and I
Yeah.
kind of think of attachment as a system of meaning. And one of
Yeah.
the biggest pieces of trauma and the biggest pieces of addiction is changing those systems of meaning. So I have to learn as an avoidant. I have to learn to allow people closer than feels comfortable.
Right.
While I'm trying to gauge that it is safe. I'm not saying
Mm-hmm. Mm-hmm.
let anybody in willy nilly.
Right.
But if somebody gets too close, one of the easiest things for me to do is to blunt that intimacy by doing something outside of intimacy. If I'm an
Mm-hmm.
alcoholic, it might be
Mm-hmm.
drinking. If I'm a drug addict, it might be drinking. But as a sex addict, the easiest thing for me to do to keep you at a distance, even if you don't know it,
Yeah.
is to act out in some way and have that secret. If I have that secret, you know, I can have a little bit of safety,
Right.
even though it's not really safety, but it feels like it. If I'm on the other side of it and I'm that love addict, I'm going to chase after you because I need you to make me okay. And without
Right.
you, I'm nothing. So I'm going to chase that. I think attachment is. I mean, we single these things out into different categories. To me, they're not. They're all
Mm-hmm.
one category.
Yes.
They're all chapters in the same book, and
Mm-hmm.
so attachment is
Mm-hmm.
hugely important to healing. Matter of fact, if you work on your trauma and you don't work on your attachment, you're highly likely to relapse in trauma behaviors or trauma reactivity. If you work on your attachment and don't work on your
Mm-hmm.
trauma, you're going to fall back in
Mm-hmm.
attachment behaviors, and they all go right back into addiction. If I'm not working on both of those, you got to work on things holistically, and it's
Mm-hmm.
all the pieces of the puzzle.
That's beautifully said. And I just wanted to share a quick story because I just had this conversation with someone the other day. A client was talking to me about his long-term relationship with pot and porn. And that's been his long-term relationship since he was a teenager, and he's 40 now. And so he really has a very complicated relationship with love and intimacy and certainly romance. And so, in a way, when we're talking about attachment, we're talking about very complicated relationships with love and intimacy. And in his case, it was a survival strategy for many years to use the pot and the porn to try and feel better. It was an attempt to feel better or different than what he was feeling, which was a lot of pain. And now he's finally saying, I'm profoundly lonely here and I'm interested in relationships. I'm
Good.
terrified of them, but I'm interested. And so we talked about, because I tend to have a relational component to the work that I do for sure. I was talking with him about what it was like to be having this new relationship with me, and how he was talking about some intimidation he was feeling, some fears he was having, and I was just loving it because he was being so honest and so direct about really what he experiences in general, but he's showing me and helping me understand what it's like to be so uncomfortable in his own skin. So I couldn't agree more. I think that it's all of the pieces of the puzzle that are necessary, and ultimately that commitment to making sure that all these areas of healing and all these areas of trauma and addiction recovery are being addressed.
I have a big smile on my face as you're saying that, because that's everything we believe in the healing, and it's not avoiding that underlying
Mm-hmm.
loneliness that lives
Mm-hmm.
there. It's facing it, and I mean, I loved what you did. The work you did with them sounds wonderful. And it sounds like you have that therapeutic alliance in exactly the way that works. And but it's
Yes.
uncomfortable, and nobody wants to be uncomfortable. Nobody wants to feel the ick. And what I always tell my clients is, you're feeling it. You're just pretending you're not. You're just ignoring what's really there and avoiding it, and that'll work for a while. If you're in treatment, it's because it stopped working. And
Yeah.
and that's why so many of us will stay status quo, because on some
Right.
level it works. I mean, there's a reason we go to it. And
Mm-hmm.
when we get to that crisis place where you can do the work that you're talking about, it's a beautiful thing, but a painful thing.
For sure. I heard Pat Carnes speak many, many years ago, and I'll never forget this particular quote. He said that the good news is in recovery, you've got your feelings back. The bad news is in recovery, you've got your feelings back.
It'll be good. I can hear Pat's Minnesota accent as you say it.
Exactly. So, Tom, I so appreciate you joining us today. I really enjoyed getting to know you better and understanding the intricacies and ins and outs of what your program has to offer. I've known about you guys for a long, long time. And I just am glad that we've had this chance to share some time together.
No, thank you for the opportunity. It was really good getting to know you a little bit.
All right, Tom, take good care, and hopefully our paths will cross again.
Absolutely. Take care.
Thank you for listening today. It was so terrific sharing the time with my colleague, Tom Pecca, and discussing this really vital topic that affects those affected by compulsive sexual behavior. Tom can be reached through his website at www.theguesthouse-Ocala.com. Be sure to give us a 5-star rating on iTunes, or please share our podcast on Spotify. And if there are any other topics you'd like us to discuss in the future, just let us know. I look forward to you joining us on future podcasts, and thanks once again for being with us today.